Welcome to the video demonstration on the long case examination in pediatrics. And in this demonstration, we are going to demonstrate how to present a long case on a child having bronchial asthma. And you know that in your clinical examination for the final MBBS, you will be given approximately 40 minutes to be with the patient to gather history and perform physical examination, and then formulate a summary and a problem list. And then you will get another 20 minutes with two examiners, first to present your history and examination findings and the summary, for which you can take approximately 10 minutes, and after which you have to discuss the case with the two examiners for the rest of the 10 minutes. Let's watch this demonstration. Good morning.
Good morning, sir.
I'm one of your examiners. This is your pediatric long case, and you will get approximately 20 minutes to present your history, physical examination findings, and then to present a summary. And until your 20 minutes examination time is over, we'll then get time to discuss your patient. Is that clear to you?
Yes, sir.
You can start now.
Miss Nuwani, a 7-year-old school-going girl from Kandana, the second-born child of non-consanguineous healthy parents, presented with fever, cough for 3 days, shortness of breath and wheezing for 1 day duration, and chest tightness for 4 hours duration at the day of admission. The history was taken from the mother, who was educated up to grade 8 and is a housewife. She is a known child with bronchial asthma since the age of 6 years, where he had infrequent cough and wheezing episodes, who was on meter-dose inhaler with defaulted treatment and follow-up. It was due to the social issues, which I would be elaborate more on in this social history. Before 6 years of age, she was apparently well. This current episode was preceded by cough for 3 days duration, which was triggered by dusty environment due to a house repair. Cough was productive with a diurnal variation. It was worsened with time and associated with shortness of breath more towards the night, wheezing for last 1 day duration. On the day of admission, symptoms worsened a lot with the chest tightness and a spike of moderate fever, which was responded to paracetamol. At the day 1 of cough, he was seen by a general practitioner and was treated with chlorpheniramine, azithromycin and salbutamol for 2 days. With the second day of his illness, he was producing mild amount of sputum with cough, which was disturbing his activities and sleep. It was also associated with chest pain, post-acid vomiting and reduced intake. The child was unable to speak a sentence and he was admitted to the hospital thereafter. On the day of admission, the child was restless and had severe cough with wheezing. The nebulization was done 3 times with the assessment in between and transferred to the ward, where special medications were given according to the mother. Several blood tests were done with a chest X-ray, and which was told to be having some changes, and he was started on IV antibiotics. He was on oxygen throughout this hospital stay for about 2 days. The frequency of nebulization was reduced from next day morning, since he was improved a lot with symptoms and with general appearance. He was apparently well except once in 2 months upper respiratory tract infections up to 6 years. Admission to hospital 1 year back with similar symptoms needed 5 days of hospital stay with special medications. Since the frequency and the severity of respiratory symptoms got worsened with time, it needed monthly nebulizations. Since the first admission, mother noticed several triggering factors which caused cough and wheezing. It was like dust, cold food and excessive crying, etc. Activities are also disturbed, including playing, schooling and sleep. All had symptomatic relief with medical attention. There is no chronic cough or tuberculosis contacts, no edema, no orthopnea, paroxysmal dyspnea or exercise intolerance, no epigastric burning pain, regurgitation or vomiting, no recurrent chest infections suggestive of chest infections or poor weight gain suggestive of suppression. And the rest of the systemic inquiry was unremarkable. She was known to have allergic rhinitis since 3 years of age. There are no previous surgical illnesses and she has a known allergy to seafood. There is no other known allergies for drugs or plasters. She is on salbutamol and beclomethasone inhalers and also Montelukast tablets. But there is a very poor compliance and defaulted follow-up. The inhaler technique was also incorrect. There is a positive family history of bronchial asthma to the father who has also had childhood bronchial asthma and was on inhalers. Child is a product of an unplanned pregnancy without proper follow-up and mother has had gestational diabetes mellitus during the antenatal period. She was delivered via an emergency lower segment cesarean section due to the fetal distress with a birth weight of 3.5 kilograms. And she was admitted to the PBU for respiratory support and then discharged after 1 day of oxygen support. BCG vaccine was given before discharge. And immunization wise, he was given all the vaccines except for the last vaccine at 5 years of age, which was missed by the mother due to the negligence. But there were no adverse effects following immunization. Growth and development is age appropriate and she has missed her schools frequently due to the frequent episodes of hospital admissions and respiratory symptoms. So there is a poor school performance as well. She was exclusively breastfed for 6 months of his first life and then started on complementary feeding. Currently she is taking 3 main meals and a snack which was with average quantity. She lives with mother, father, elder brother and maternal grandmother at home. Father is educated up to grade 5 and he is a labourer who is 40 years old. Mother is 36 years old and she is a housewife. Father earns about 30,000 per month and they have many financial issues. House is a single story, partly completed house with 2 rooms, each with 3 windows, living room and a kitchen. There is a cement floor and roof made with asbestos sheet. Home is close to the main road and 3 of them shares the same bedroom. Mother cleans the house once in 2 days, changes bed linen once in 2 weeks and they do not have curtains for their windows. And they keep the windows open at nights. They also have a cat at home as a pet and they use gas stove for cooking but smoke is not coming in. There is exposure to passive smoking since the father is a smoker for 10 years duration. Mother has restricted cool drinks and cold meals since the baby can trigger wheeze and cough due to those things. The nearest hospital is North Colombo Teaching Hospital, Ragama, which is 20 minutes away from their home, but they do not have a vehicle at home in case of emergency. Mother has few myths about the inhalers and nebulization, so she does not encourage using of them properly according to the medical advice. They do not have a crisis plan, but even though the child is not actively involving in management plan, he is capable of using the spacer and the meter dose inhaler. On examination, the weight is 25.4 kilograms, which is in between 50th and 97th centile. Height is 120 centimeters, which is just above the 50th centile. Body mass index is 17.64 kilograms per square meter, which was lying in between 1 plus 1 SD to median. She was ill looking, but there is no dysmorphism, adequately grown and afebrile. She was tachypnic, dyspnic, but not pale. There was nasal flaring and the use of accessory muscles for respiration. There were no clubbing or ankle edema. There were no dry skin and rash, which is suggestive of eczema. The patient was hemodynamically stable, having blood pressure of 100 by 80 millimeters of mercury, pulse rate of 60 beats per minute with good volume. In respiratory system examination, there were no chest wall deformities, no scars. but subcostal, intercostal, supraclavicular recessions were noted. The chest moves symmetrically with respiration, trachea was central and had a respiratory rate of 40 per minute. The saturation of oxygen was 88%. Percussion note was resonant. In auscultation, the air entry was equal with vesicular breathing, but I could hear bilateral polyphonic bronchi all over the lung fields. Hallucin sulcus was noted with hyperinflated lungs. Rest of the abdominal examination was unremarkable. There were no signs of heart failure, and the central nervous system examination also were normal.
Thank you. Can you summarize your patient?
Yes, sir. Ms. Nuani, 7-year-old school-going girl who is diagnosed to have poorly controlled bronchial asthma since 6 years of age, this time presented with an acute severe exacerbation of poorly controlled bronchial asthma, which was precipitated by a lower respiratory tract infection. And the patient is having a very poor compliance on the treatments and management, and also an incorrect inhaler technique. She is known to have allergic rhinitis as well, and she has missed his 5th dose of DT vaccine, and she has several financial issues and social problems as well. There is a positive family history of bronchial asthma. On examination, she was adequately grown but ill looking and in respiratory distress with bilateral polyphonic bronchi all over the lung fields. There were no evidence of corticosteroid overdose or salbutamol toxicity, and she was hemodynamically stable.
Thank you. Can you present your problem list?
Yes, sir. I would like to categorize the problems according to short-term medical, long-term medical and social problems. In short-term medical problems, the first thing was this was the second episode of acute severe exacerbation of poorly controlled bronchial asthma, which was precipitated by a lower respiratory tract infection. Then the long-term medical problems were allergic rhinitis, poor compliance on the treatment due to myths and unawareness, and the incorrect inhaler technique and missed dose of vaccination. There were several triggering factors for the cause of the illness, and the social problems were there were major financial issues, food restriction and impact on schooling and exercise, reducing the quality of life of the child, and exposure to passive smoking as well.
Assume that you are the house officer of the ward where this child is going to get admitted to. Can you explain what you are going to do if the child presents with the same set of symptoms?
Yes, sir. Once the baby is admitted to the hospital, I will quickly give him a bed at the acute side. Then I will quickly assess the baby and connect the baby to a monitor to check the vital signs. Then I will assess the airway, breathing and circulation. And I will keep the baby in the most comfortable position, preferably prop-up position, or if it is comfortable for him to be on the mother's lap. Then I will give him oxygen which is humidified and warm with a tightly fitting oxygen mask. Then I will reassess the oxygen saturation, and if it is less than 92, I will continue giving oxygen. Then I will proceed to the back-to-back nebulization with inhaled salbutamol, and which I also can add ipratropium as well. Then I will assess the baby in each 20 minutes and continue it until 1 hour. Then I will again assess the baby. If the condition is still not improved, then I will start oral prednisolone if the baby is capable of getting oral medication, and if it is not, I will start him on IV hydrocortisone. Then again I will assess the baby. If she is still wheezing, then I have to go for the second line drugs. In that I have to give IV magnesium sulfate, but before giving magnesium sulfate, I have to assess the baby's hemodynamic stability. Then I will check the blood pressure, as it can cause hypertension and muscle paralysis. Then preferably I would give magnesium sulfate in the HDU setting with the 40 mg per kg dose over 20 minutes. Then still, if the wheezing is not settling, I would go for IV aminophylline, but I want to make sure the baby is not on long-term theophylline. If he is on long-term theophylline, I should avoid the IV aminophylline bolus and continue only with the infusion. If still the baby is not getting improved, I can also try with IV salbutamol as well. Then I will assess the baby continuously with the vital parameters.
You said you wanted to give nebulized salbutamol. Can you tell how you are going to do that?
Yes, sir. I would preferably give oxygen-driven salbutamol nebulization because to avoid the risk of ventilation perfusion mismatch.
Okay, now with your treatment, the child improves. Can you tell how you are going to plan discharge of this child? What are the important things to consider?
Yes, I want to assess the symptoms of the patient, whether it has got a good symptom control with the optimum doses of medications. Then I have to achieve a good quality of life of the child with minimal or no side effects of the medications as well. So I will plan the medications with reduced frequency, and I have to specially educate the family since the patient's family is having a very poor knowledge regarding this disease. I have to educate the family regarding the cause of the disease, how it is exacerbated and what to do in exacerbation, how to identify them. And
so once we have discharged, 2 weeks after, the child presents back to you, and then you meet him in the clinic and presents with a new set of symptoms suggestive of a mild exacerbation. Can you tell how you are going to evaluate an approach to that?
First, I have to ask for the history and I have to quickly examine the baby, and I have to see what was the triggering factor for this episode. So, I have to assess the inhaler technique and I want to ask for the triggering factors which can be the cause for this exacerbation, and also I have to ask for the compliance as well. So, after assessing all those things, then I want to ask them to maintain an asthma diary as well for the early identification of the exacerbations.
What do you think the role of the school teacher in management of fees of a child of 7 years old?
Yes, sir. Since the child is going to the school recently, I want to ask the mothers to advise the teacher. If the mother and the father is not capable of doing this, we have to inform them with a letter. So, I want to ask the teacher and I want to educate her regarding the child's disease condition and what to do if there is any exacerbation occurred at the school. Then I have to tell that the child is on these medications and how to use them and what to do in a case of emergency.
You said in your history that the child had missed the DT vaccine, which should be given at 5 years of age. What can you do about that?
Yes, sir. Now I can give that dose at the time of admission, but before that I want to ensure that the baby is not having a febrile illness and she is not ill at the time of administration of the vaccine.
And you said the child is having symptoms of hay fever, allergic rhinitis.
Yes.
How do you manage symptoms of hay fever?
In the management, there are pharmacological and non-pharmacological methods. In non-pharmacological methods, I want to identify the triggering factors and I want to avoid the triggering factors causing the hay fever. In pharmacological management, I can prescribe non-sedative antihistamines and also nasal corticosteroids as well.
What important precaution would you take, especially when advising somebody to use nasal corticosteroids?
Yes, sir. In administration of nasal corticosteroids, I want to preferably advise the mother to use that spray directing towards the lateral side walls of the avoiding the nasal septum, because it can cause a perforation of the nasal septum with the long-term use of nasal spray of corticosteroids.
And you said this child is having multiple financial problems. How can you help them out with their financial problems?
Yes, sir. In that case, I can contact the Grama Niladhari of their living area and I can contact the social services department which can give them funds to help their financial issues.
You said this child is having allergies. Assume this child presents with a severe allergic reaction like anaphylaxis. What are the important steps in managing a child with anaphylaxis?
Yes, sir. Initially, I want to quickly assess the patient and detect the baby is having an anaphylaxis reaction. Then I want to call for help. Then I would assess the airway, breathing and circulation. Since I have detected an allergy reaction, I want to give him IM adrenaline 1 in 1000 0.01 milliliters per kg dose to the anterolateral aspect of the thigh. Then I will continue assessment of the baby, and if he is not getting improved, I want to repeat the dose of IM adrenaline.
Thank you.